Thank you, Manuela, and the team at Ibex for inviting me to present this. Um, I'd like to present essentially our journey as one academic pathology department. We are just a standard academic pathology department, 25,000 surgicals, about 12 to 18 anatomic pathologists, residency training, fellows, all the usual stuff that most of the academic centers have. Um, and we are somewhat subspecialized, but not 100%. So that's me there. And I'm going to take you on a journey of our department's digital transformation from very traditional to what I think is really at the forefront of where we should be going. Uh, and I just wanted to, that's my objective. I want to have this disclaimer. I work for a nonprofit academic center with strong non-endorsement and conflict of interest policies. So while I'm going to talk in detail about various products that we've used, but there's a lot of vendors out there, and I'm not making any actual specific endorsements here. I have no conflicts. So that's your traditional anatomic pathologist, has virtually unchanged since 1830. Okay, the stack of papers may have become a little smaller and there's a computer in there somewhere, but this is how a lot of pathology is going on even today in the United States. The future, well, at UTMB, the recent past, is that we sign out we are 100% digital. We were one of the first all digital academic pathology departments in the country, a few steps behind Ohio State, which I think was the better known. That's my office. We are an island off of the coast of Texas, 150 miles away from Houston. And you see there, already you see my computer screen. That's where I sign out my cases. I do GI, GU, and there's that microscope. That particular day, we had a whole stack of slides in folders. So for first couple years, we were hybrid mode, like a lot of places that are going digital are. In July of 2023, I decided that we had had enough time with the training wheels, as I call it, and then I took off the training wheels. We are now not distributing slides. The slides go from histology to the scanner, and from the scanner to the files. And all my pathologists are working in this mode. I'm the only one who's actually gotten rid of my microscope because I do a lot of meetings and I want to be face-to-face. My cytology colleagues still cling to their microscopes. We're going to change that as well. Many benefits of doing digital pathology. I used to give this talk about why to go digital. I think the highlighted one at the very bottom, artificial intelligence tools, is really the biggest driver of digital transformation today. And so we're going to talk about that. What can we do? Once you digitize a slide, there's data there embedded in all those pixels there. That's when you can really start doing the math that's behind all of this AI, right? So, of course, we're here to talk about prostate AI and Ibex, and multiple different AI algorithms are out there, and two of them are represented here. We looked at them, and we selected Ibex to go and partner with. So this is our current structure. We have all our slides are scanned using Philips scanners. We traditionally view our slides on the Philips IMS. Ibex we had to build this VPN tunnel that goes in and pulls the slides that are marked for Ibex. So Ibex comes in, pulls those slides, does their magic, and gives it back to us using those screens. But before an academic center can go digital or go with AI, there's a lot of hurdles that have to be overcome. So I just want to walk you on the prequel to our story And if this hadn't succeeded, we wouldn't have been able to go to the next step. October 31st of 2023 at the Digital Path Association was when I first spoke with Justin, our salesperson at Ibex, and understood the product, spoke with Dr. Pentanowitz, who is an early champion, and said, he gave me the thumbs up. That meant a lot to me. I got the on-site demo in our department. My pathologist gave me the thumbs up. We also wanted to include our urology colleagues, bring them along. Justin did a demo for them. They bought in, they love it. And then we had a 6-7 month period of just waiting for IT security, risk, legal, contract review, all the way to the headquarters of the UT system. And you need a champion advocating, and I had to send a lot of reminder emails and do all the stuff that we hate to do, but we must do, persist. And unfortunately, that's one of the biggest challenges in digital transformation in pathology today. But near-death events notwithstanding, we had the contract signed in July, and the implementation was so much easier. I mean, we had our kickoff. That's our project plan. We kept to plan. We did the IT integration. We did the validation. I have a great team. Okay, I have wonderful IT people, histology lab people. I was fully actively engaged as the champion for this. Got on those calls. This is our workflow today. When a prostate biopsy comes into the department, we accession it into our Epic Beaker system, and it is assigned to the pathologist who will be signing that case out. It's assigned to a resident or fellow who's designated to review the cases. In the lab, when the slides are, there's a Epic to Philips integration. So in the lab, someone goes in and assigns a case to a fictitious pathologist we had to create within the Philips IMS we call that pathologist prostate Ibex. So once that assignment goes, the signal is given to the Ibex people to pull that particular case and give us, within a few minutes, this image, right? I'm not going to go over too much of this because several of the talks have, and you guys have seen this, but that's our Ibex viewer. I've given you two examples. On the left is the one which is the yellow color, orange color, the middle or the medium likelihood, and then the red one on the right, which is a high likelihood of cancer. These were our numbers. So of course, I don't care about the FDA, frankly. I have to do my own validation, whether it's an FDA approved system or not. I'm going to do my own validation. That's a clear requirement. And so we did the full validation the way we should, defined it, calculated this. Sensitivity was pretty high, specificity. Our numbers were not like the one that were submitted to the FDA. But that's what you have it. And I'm calling only using the high diagnosis as the criteria. If I just look at the ones that are, so here, you look at the numbers there, about 1/3 were high. Almost all of those were cancer, except for one. Low, 97, all were negative. So our experience has been that if Ibex misses or decides that something is benign, it's benign. And as a pathologist who signs out prostate biopsies, it's the benign ones that cause a heartache. We have to spend more time on our benign biopsies. So I'm very grateful to have that function. And then I can focus on the yellow ones. So that's the traditional pathologist. That's how you sign out a case with Ibex now. I'm going to blow up that area and show you are there any GU pathologists here? There's probably at least a couple. I want to focus on that one focus, which I know this pointer isn't working, but look at that. I've outlined in red the cancer. You can recognize the double layer for that benign focus that's outside that, and the AI has also excluded it. So it's very, very, very precise in location. We all know that prostate cancer can hide from the pathologist. You're on a busy day. You might think there's no cancer there, or you might, miss it. But the Ibex can really, any AI can just pick up this. And I really like the heat map function. Here's an example. P63 immunostain really confirms the cancer. As you heard, it can help with the Gleason grading. My GU colleague says, that it's okay, but you have to, if two pathologists check with each other, there's always some variability. So it's just like having another colleague there, right? Or for us, a fellow. It helps identify perineural invasion. Imagine a so-called benign case, but there's just that one tiny focus, which happens to be a perineural invasion. You miss it. You just missed that patient's, advanced cancer. So it's been early days for us. I compared the 3 months before and the 3 months after our Ibex implementation, and we found that about 35% fewer immunostains were ordered, and we were about 20% faster in our turnaround time. So, decreased chance of misdiagnosis. Pathologists are happy. Our urologists just love the fact that we are doing this. And then I'll just talk about off-label use. I'm calling it off-label because this was not developed for biopsies. But we said, hey, what about those annoying transurethral resections? Because those can sometimes come with hundreds of pieces of tissue, many dozens of slides. And it's so easy to miss a little piece of cancer because you're expecting everything benign, right? Here's an example. There's a little focus, lights up. And we're not doing this for all our TURs just yet. And there's quite a few caveats here because of cautery artifact, erratic staining. But even when blown up, it's hard to make sure that is cancer. So here you have one off-label application. And then, occasionally when you have a radical prostatectomy, you want to find out if cancer is touching the margin, what's going on. We can use this now because we have it deployed. So there's many advantages. That's great. Okay, so that's our present. But in the next 2 minutes, I'm going to talk about something that will really exploit the power of AI. And we're now going to go into the large language models. So here is a picture of my department. In the center is Dr. Mike Laposada. He's a clinical pathologist who pioneered the diagnostic management teams. We have a private foundation grant to develop AI-assisted diagnostics, and mostly clinical pathologists, but a couple of us are anatomic pathologists there. And here's a custom GPT that we developed for prostate cancer patients. Okay, I'm going to walk you through it. It's a very detailed multi-step prompt that I developed after battling it out with ChatGPT, because if you just do it from straight out of the box, it doesn't work as well. But with a customization, which is invisible to the end user, the prompt and uploaded in its knowledge base are the existing guidelines from the NCCN and the AUA and ASTRO. And then the user just has to upload the clinical note, the urology note, the radiology MRI, and the pathology report. In this example, we scrub the PHI and we run it. So you just hit the button and it generates, I'm not going to go over this, but it generates a very detailed, customized, step-by-step report giving the summary of the salient clinical history, describing the radiology that led to the biopsy, not just rewriting the biopsy report, but actually saying, cancer was found here, here, and here. This is why we now use the guidelines and risk stratified it to this particular unfavorable intermediate risk. And it says because there was perineural invasion and cribriform pattern was present, it calculates the Memorial Sloan Kettering nomogram for prediction of lymph node mets or those kinds of things. And we then have a fully integrated, goes ahead and gives guidelines for how to manage. And this can be in our diagnostic management team report to the urologist. And then, the urologist can do what they want with it. In addition, we put the picture of both the prostate MRI and the pathology. And best part, you can then ask ChatGPT, and we have built into this prompt to also prepare a report that the patient can understand using non-technical language that can be delivered to the patient by the urologist or by us if it's a direct-to-patient communication. So that's where we think we are going to go. We're not going to stop with prostate. We're going to go next with breast. We're going to do everything very safely after complete validation and always keeping the human in the loop. I would like to say human at the end of the loop. We have to be the ones taking responsibility, signing the cases out, and of course keep monitoring because these AI tools will degrade over time sometimes, so you have to kind of be careful.